Thank you so much, sir. It was indeed a very informative and very intense presentation. And also to share, we've had the highest participation. I think the topic, as we discussed, was very interesting. So can we move on to questions from here now?
Yes, certainly.
Sure.
So let me go through some of the questions in here.
Sure.
Okay, I'll go to the top and start from there.
So the first question actually is, how does T1 relaxation helps in cardiac amyloid? Is that specific?
Okay, so that's a very good question. So how does T1 relaxation help in cardiac amyloid? Is that specific? T1 is basically looking at pathologies which are demonstrating areas of fibrosis or areas of increased extracellular volume or myocardial damage within the myocardium. Now, in amyloid, it increases. In hypertrophic cardiomyopathy, it increases. In sarcoid, it increases. In iron overload cardiomyopathy, it decreases. In Fabry's disease, it decreases. So is it specific? The answer is no, it is not very specific. However, what it is being shown currently is that if there is increase of T1, amyloid has a significantly higher increase. But is there a specific number beyond which we'll say it's amyloid? The answer to that is no. So T1, along with other parameters, will help us in determining amyloid. One advantage, however, becomes is that a lot of these amyloid patients also have renal failure. And so if you have a patient who is in renal failure and you're not able to give gadolinium, then T1 is very helpful at looking at these patients and saying, yes, this could be amyloid. Another question which came in there is, I see wide inter-observer variability in reporting percentage of late gadolinium enhancement in HCM. Is there any standard way to calculate the amount and to minimize variability? You have actually quoted the fact that there is significant variability within the percentage estimation of LGE. There are multiple softwares which are available which do the assessment in different varieties, and different methods have different functional. The best way as of now, which has been used, is using 6 standard deviations method, which is available in most of the softwares, that is found to be most reliable and most reproducible. So I would use that method for seeing that. Functionally or visually assessing LGE can be difficult and may not be very accurate. So using 6 standard deviation method is the best way. Okay, so next one is, can you make definite diagnosis of tubercular myocarditis or still requires clinical correlation? Absolutely right. We see a lot of these, and every time we say granulomatous myocarditis should be considered. Now, viral myocarditis, from our experience, tends to be much more focal or 1 or 2 areas. Granulomatous myocarditis tends to have multifocal areas. And because it has multifocal areas, we suggest granulomatous etiology. But again, we could not say whether it is sarcoid or TB based on just imaging. It needs further from there. Now, similar question which has come, how to differentiate sarcoid from cases where there is no pulmonary sarcoid involvement. So our standard practice is, we do a cardiac MR, and let's say we find something which looks like a granulomatous etiology. We would look at the mediastinal structures. We would also look at lung parenchyma, and invariably we would get a PET CT done, which is very useful in looking for any other areas of abnormalities. We found patients who've got scalp lesions in sarcoid. We've biopsied that and proven that this is sarcoid. We've seen people who've got some spinal issues with TB. We've biopsied that. How to differentiate enhanced MR between ischemia from infective myocarditis? Ischemia, you would see the differentiation between ischemic and non-ischemic pattern is purely on delayed enhancement. based on whether subendocardial area is involved or not. Non-ischemic cardiomyopathy does not involve the subendocardial area, which is spared, while ischemic cardiomyopathy involves that. Any comparison of cardiac MRI with stress echo? Okay. With stress longitudinal strain, global longitudinal strain plus contrast, also all three including SPECT. Very nice question. Okay, so there is, in cardiac MR, you have the ability of doing both first pass perfusion using adenosine as a standard stress agent, or you can use dobutamine, very similar to what you would use in MRI, in echocardiogram. Again, with dobutamine, we don't need to give contrast at all, so we can do it without contrast. The longitudinal strains is something which is again very recently come in MRI, and it is being shown to be excellent in looking at regional wall motion abnormalities and picking up these areas of ischemia much earlier than we could see with others. SPECT, I really am very categorical about it. SPECT is not good. Dobutamine stress MR is found to be much better than any other form of stress MR. Echo versus MRI, not extensively studied, but I think in areas where MRI is not available, you've got a very good echo service. Echo with strain imaging will do a good job as well. With sequence in LGE, black blood or white blood, you have shown both of them. I have heard about fiddle sequence. What is that? I'll not talk about fiddle sequence because it goes very much in detail, which is slightly more into physics. We tend to use white blood delayed enhancement more often, but black blood delayed enhancements are something which are coming up, and we have tried it more recently in there. Kindly comment on approach to cardiac masses on cardiac MRI. Cardiac masses in cardiac MR is a very good tool, not only to ascertain the location of the mass lesion, but to also characterize whether it's a benign lesion or a malignant lesion. And we have internally looked at what we have done, and our sensitivity and specificity to the final histopathology is very high, in the range of 85 to 90%, and we often get good results within that. Bedside portable MRI have come along with CT of head. Any role in cardiology? Vinod, very nice question. No, the bedside portable MRI, which has come for brain, is a much smaller machine, and it is capable of doing small field of view areas. And cardiac MRI, I do not expect it to come for at least next 5 years, maybe 5 to 10 years time. There may be something where we can do a portable one. How to differentiate constrictive versus restrictive cardiomyopathy? In cardiac MR, we can look at the dynamic collapsing, or the interventricular coupling gets lost, and there is a good expiratory variation of this, which we can see with dynamic cardiac MR images. Also, we assess the pericardium at the same time and look for the myocardium. So you have to look at the dynamic movement of the ventricle to look at the interventricular coupling in there. Ranjit, do I have some more time to go through these questions?
Yes, sir. I mean, as
Okay.
long as you are comfortable. I think the list is actually very long and still pouring in.
Okay. Oh dear. Okay. Is edema in sarcoid heart a marker of active disease? Can we treat on grounds of it if no PET available? Yes. If it is present, if edema is present on cardiac MR, it means that it is active. However, absence of it does not mean it is not present. So PET, we have seen that a combination of PET and MR is very useful in putting things together and managing these patients. Okay, one CT question, comparison of coronary calcium with carotid iliac aortic calcification with ultrasound. There has been a lot of literature and there is good, strong evidence that carotid ultrasound looking for early intimal thickening is a risk predictor for coronary artery disease. But direct comparison with calcium score, I am not aware of this. So they, as a separate marker, they are very useful, but direct face-to-face comparison, I am not aware of this. Rohit Valse has asked a question saying that recently there was a paper showing that calcium score of more than 1,000 is associated with lesser incidence of coronary events due to plaque stabilizing effect of calcium. The answer to that is I have not come across that paper, so I can't specifically comment on this. But in my personal experience, we have seen people who have severe calcium score of 3,000, 4,000, 5,000, but on angio, they do not have any occlusive coronary artery disease. So yes, there is a plaque stabilizing effect of calcium. There is also positive remodeling of the coronary artery as part of the coronary artery disease. So I think this is very good in using that as a test. Vinod Vijan asks me, what is the radiation with one coronary CT and cumulative risk of calcium score in future? So calcium score radiation risk is equivalent to somewhere in the region of 20 X-rays. So if you're just doing calcium score. If you're doing a CT in a very well controlled, in a very good institute, a high-end scanner, then you are looking at a X-ray burden of somewhere in the region of 100 to 200 chest X-rays. Now, what is very interesting is that when we go to a intercontinental flight, when we are flying at 25,000 feet, we are all exposed to radiation. And those radiations are very similar to what we are talking in terms of CT, etc. But we never think about those radiation. So the risk of developing cancer, it's all stochastic relationship, which basically means that it is just a chance. What does that mean? Will I have a coronary CT and not worry about cancer? The answer is yes. Will I have it every 6 months? No, I would not have it. I would rather have it every 3 years. Then you would have no problems with that. Dr. Lokre has asked me a question of give a word about CT FFR. CT FFR or CT fractional flow reserve currently is being done by only one company, which is FDA approved, called as HeartFlow. This is a US based company. Any CT scan, good quality CT scan can be sent to this company and they will give us very reliable, good reports. The cost is tremendous, in the region of $1,300 per patient. So it's very expensive. Other companies are coming up with their equivalent, but they are not yet FDA approved in that. So cost is the major limiting factor. Rajshri Arulnidhi has asked me, for viability, which is better, cardiac MR or PET? If you look at the evidence, the sensitivity and specificity of PET is in the region of 95 and 97%. Cardiac MR is in the region of 93 and 95%. So PET is 2% superior, but MR gives you much more additional knowledge without any radiation exposure, and you get to see all the other poor prognostic features or good prognostic features in cardiac MR. So if I have a choice between the two, I would use cardiac MR. But if you are in a situation where you only have PET, then definitely PET, it's not a problem. CT, not that good. Okay. Doing MRI patients with prosthetic valves and sternotomy wires, is that okay? This is from Vijay. Vijay, sternotomy wires, not a problem at all. As soon as the sternotomy is done, we take patients within 24 hours as well to do any part of the body MRI examination. Prosthetic valves, we need to find out what kind of prosthetic valve is there. As a thumb rule, anything which is done after 2010, they are all relatively MR compatible, but you need to know what these MR valves are to take a call in there. Nowadays, Jabraj Ratinaswamy says, nowadays almost all stent prosthetics are MRI compatible. I totally agree with you. Coronary artery stents are absolutely fine, should not be an issue at all. Some of the prosthetics which are older than 2010, I would be cautious, find out about what they are, and I would do them. 1.5 Tesla machines are better than a 3 Tesla machine for this. Let me see if I can get some people have given me good comments. Thank you very much, guys. And my PC has said, in acute conditions after myocardial infarction, edema will cause problem in determining viability. How to overcome this problem? This is very, very good question. Okay, this is where people give me anecdotal evidence whereby a patient comes in with acute myocardial infarction related symptoms. You do a cardiac MR for viability, and in the less experienced hands, they call that as non-viable myocardium. The patient is sent on medical treatment. 6 months later, ejection fraction improves. You do a PET, and PET shows viable myocardium. So in acute setting, there is diffuse edema, which leads to significant swelling of the myocardium and leads to overcalling of the area of infarction. So always it is better to report your delayed enhancement along with edema imaging, because that helps you in determining at-risk area and the areas of penumbra where you're able to differentiate which is edema and which is true infarction within there. Any experience in dengue myocarditis? Yes, we've had few cases of dengue myocarditis. We have reported a case of leptospirosis myocarditis. We've also reported HIV myocarditis in patients. Dengue myocarditis is no different. There is no focal areas of involvement that we have seen, but we have only seen 1 or 2 patients. There may be, I suspect, more cases of COVID also, which may be coming in. And it is important that we able to see these cases also. Dr. Kaveri is asking me, in calculating ejection fraction in a patient with aneurysm, do you exclude these areas in calculation? The answer to that question is no. We include that area in calculation because they are very, very important in looking at the volume of the ventricle as well. Ranjit, there is a lot of questions with regards to sending the PowerPoint presentation. Is that something we can send to people? I'm happy to share my presentation, but would you be able to send it to them?
Yeah, so sure. So normally what we do is we request people to leave in their email ID,
Sure.
and then we can, if you accord your approval, then we can share forward.
Okay.
And of course, the session link.
Okay, sure. I think we'll take 2 more questions if you're okay with that.
Yeah, absolutely. So,
okay. So what is the protocol for stress MRI? So Dr. Lokre has asked me this question. Dr. Lokre, it depends on what you're doing. So let's presume stress adenosine perfusion is what we are talking about. So what we do is we do our routine cine images for functional assessment. We give adenosine at a dose of 140 microgram per kilogram per minute. We stress the patient for 3 minutes or until a point where they show hemodynamic response under optimal measurement of blood pressure, heart rate, and monitoring. At 3 minutes, we infuse them contrast, gadolinium contrast, and we do perfusion imaging. After 10 minutes of perfusion imaging, we would repeat this sequence at rest to look at the difference between the stress imaging and rest imaging. Dr. Vijay has asked me, role of calcium scoring in aortic valve disease. Yes, there is a very, very good article which is available in Radiology Journal, which talks about calcium scoring and assessing the severity of coronary aortic stenosis. So it is very useful in that, and yes, you can use it. Another message from Kelly Kosama. Is there any specific pattern of COVID-19 in cardiac MR or CT? CT, yes, not in coronary or cardiac CT, but yes, in the lungs, bilateral, peripheral areas of ground glass opacities are what is classically seen in COVID-19. In cardiac MR, the cases which have reported, I have not seen any cases live in our institute as of now, but COVID-19 myocarditis cases that have been reported, they have typical myocarditis features where you will see mid-myocardial to epicardial enhancement with some pericardial effusion, which will be also useful in doing that. Global subendocardial in amyloidosis, global subendocardial enhancement in amyloidosis versus ischemic subendocardial differentiation by Dr. Rajesh Natuva. Rajesh, the differentiation, if you have a patient that has got diffuse subendocardial enhancement, I would look at the T1 mapping results. And often what happens is there is a zebra pattern of enhancement with the amyloid. Subendocardial, there is diffuse enhancement. Mid myocardium is normal. And then again, along the epicardial aspect, there is diffuse enhancement again. So that is very much classical of amyloid. There's also something called as a TI scout or a look locker sequence, whereby we look at the nulling of the myocardium, where it is very good in assessment of amyloid, where we can see. STEMI patient conservatively managed. Rajesh is asking me this question. Patient having severe LV dysfunction, coronary angiogram showing triple vessel disease, plan for viability based on revascularization. What is the earliest period post-MI we can do viability assessment? Role of dobutamine in these subsets? Very, very nice question, Rajesh. I think this is something every imager needs to be very clear of, and it's very useful. So we have patients who come in with acute presentation, angio shows triple vessel disease, and we need viability assessment. Now, if this patient can wait medically, the decision can wait, then you wait for at least 2 to 4 weeks before doing viability assessment with MRI, because the edema would have gone down and it'll give you very good images. However, if you cannot wait and it is an imperative decision which needs to be taken urgently, then what we do in these patients is we do edema imaging followed by delayed enhancement imaging. And we see while the patient is on the table, we look at both the images together and we look and see whether we are able to differentiate areas of irreparable damage to areas of edema but viable tissue. If we are not able to differentiate, on the table we do low dose dobutamine, and it is extremely useful, and by far all evidence suggests low dose dobutamine is the best test for assessment of viability in this subcategory of patients. Let me see, Hanumant Reddy, who's a good friend of mine, says that how to go ahead with differentiating cardiac MR imaging modalities to assess cardiac viabilities. Well, a lot of it does depend whether you choose between echo, cardiac MR, or PET, depends on 2 or 3 factors, okay? In an institute where you have all the 3 available, okay, I would definitely go for cardiac MR because it gives you a lot of other information for free and it is very good. If you're in an institution where your echo services are much better than the other services, then definitely use echo. And if you're in an institution where your nuclear medicine services are much better, then I would use that. So availability and the expertise makes a big difference in terms of which modality to choose between that. So I think by that, I have answered almost all the questions. Thank you very much for every one of you to join into this presentation. And I hope I have convinced some of you to start using cardiac MR more often than what you have been using so far.